everyone to Take It to the Max webinar. Tonight we were talking about advanced PDO threading, precision, anchoring, and contour. I'm Jacqueline Luongo, and I'm going to be your host. I encourage anybody that is live at any point, please put in the chat any questions that you have for Gio and Abby. We have a lot of videos to show, great before and after, so much content to go over. So let's get started. And first, welcome Gio. Welcome, Gio.
Hi, everybody. Nice to see you guys all. Well, not see you, but glad you're on here.
Yes, absolutely. And Abby, welcome. Please introduce yourself quickly. You were a guest back in October as well. So this is a bit of a part two to that last webinar. Welcome back.
Yes, thank you. I'm Abby Gaskell. I'm a board certified physician assistant, and I'm excited to be back and on the snow day, I guess. So
yes, absolutely. And I hope that we do have a really great live audience today because of that reason. Half the country is a bit snowed in, so we have your attention. At the end of the webinar, we do have a really great promotion for those that are listening live. So stay on for that, and we'll get started. So we'll go over everything that we are going to review. And again, please put in any questions that you may have that may be relevant or maybe not. And it could be just about threads. Abby and Gio are both going to talk about dual needle. We are going to talk about Levo Locks. We're going to talk about just understanding the whole umbrella of it. And we're going to show some videos as well. And let's start with the first slide. Gio, you want to take this one?
Sure. Understanding the difference between the threads and why we use what we use. There's the cut threads, and then there's the molded threads, and then there's the duo. What we have found in our 10 years of teaching threads and doing threads is that we find that the regular laser cut thread is great for lifting. We love our molded ones for anchoring. So to use them together just is the way to go. You don't just use one type of thread and get all your results. The duo is something we introduced 2 years ago. Pretty much a game changer. It is a molded thread, and it really just gives you a little more ability to get better results on the neck. Abby, what are your thoughts on?
well, I'm just not going to lie. Initially, when I started saw the duo, I was a little intimidated, but it's quickly becoming one of my favorite threads. It can be used in so many different places. I think the important thing to understand, and this is what I tell when I'm training new accounts, you need to walk before you can learn how to run. This is more of an advanced technique and requires just a lot of experience and having a lot of patience underneath your belt. But what I love about this, I love it in the submental area. I love it for a brow lift. I love how I can use this to complement my other threads. I'm not just typically doing just dual needle or traditional vector. I'm usually combining, as you'll see when I get to some of my techniques, multiple threads and using the least amount of threads possible to get the best results. And I love our dual needle.
I have to agree. The dual needle really comes in and finesses, I would say, everything. And yes, for eyebrows, I think they're a game changer. I think that, but like you said, you really need to know the in-cannula threads and be confident with that. We do not teach the dual needle at a beginner training. We don't even tend to teach it at an advanced. We try to teach the duo on its own. It's actually a pretty easy thread to use, but it is intimidating. So what we find is that if you don't have the confidence level to deal with complications, this is not a thread I'm going to put in your hand right away.
Awesome, thank you. Next slide.
The importance of USP sizing. Threads come in certain sizes. The size determines the thread strength. And it's not the cannula size, it's the thread size in the cannula. You can have a 17 gauge cannula and have a 2-0 thread in there. Or you can have a 18 gauge cannula and have a size 2 thread. you really need to understand what those sizes means, because what we find is people try to compare apples to apples, oranges to oranges with other companies, and it's not, because what'll happen is they'll compare the cannula size. That does not determine what's inside the cannula, and it's what's inside the cannula that determines your results.
Great. Awesome. Next slide. Do
you want to talk
Abby?
about this, Abby?
Yeah, so the vertical enhanced technique, so this is a technique where we can use Levo Lock, and then my personal favorite is to use the Levo molded max thread here. I jokingly say when I go into train accounts that depending on what trainer you get, we're kind of like trading cards. We all have like our threads that we really like. But it's but it's not like Gio loves Levo Locks. I love the Levo molded maxes. Shireen and some others love like regular molded. We all have our favorite threads. But for the vertical enhanced technique, essentially what we're going to do is we're going to have 5 entry points. We're going to make an entry point at the corner of the eyebrow. We're going to make one above zygoma going back into the hairline, below zygoma going back up into the hairline, about 1 centimeter in front of the tragus going straight up into that temporal fat pad, and then at the corner of the mandible going straight up into the temporal fat pad.
Yeah, we love this technique for somebody younger that doesn't have a lot of heavy weight falling medial. And she called it, like, I love the Levo Lock in this, but some of our girls love the molded max. It really becomes, that's the point of trying different threads, is figuring out what your favorite is for your results. That's a procedure that I would never use a cut thread with. It doesn't anchor well for it. So if you're going inferior to superior, you're going to want to use the Levo Locks or the molded maxes, or molded.
We have a video. We'll play audio. I can't hear it. Can you guys hear it?
Nope.
No.
Love these things.
I know. Of course, technology.
How come I don't even remember videotaping this?
I think this was the patient in Fort Lauderdale, like 2 years ago with Rachel.
Oh, it was at the trade
right?
center.
Yeah, that's
Okay.
right. That's right. Let's see.
I lost you.
Hi everyone, this is Giovanna
Can you
with
hear me?
PDO Max, and I'm here with Rachel, one of our awesome trainers at PDO Max. Today we are going to show you how to do a vertical enhance with Levo Locks. We have one side marked. Now Rachel's going to mark the other side for you to show you exactly how we want this marked.
So we're going to start here with the corner of the eyebrow. We can see where Gio marked out here. So this is going to kind of get us that nice eyebrow lift. We're going to just go straight back into the hairline. Then we're going to mark out our lateral canthus line. And our second mark, as you can see, she's probably, I would say, about 1.5 fingers if you need kind of that measurement reinforcement for our next thread. Then our next line is, if you look at where the cheek, underneath the cheek, kind of you got your maximal projection point, and we're kind of coming down below that, so we can think about getting the thread in here to really pop that cheek up. So we're going to kind of come about here, and then it's going to sweep kind of under that zygoma as well. Our next one is kind of at the, this might be able to see better over here, at the hairline. I'm just thinking that camera. Kind of at the tragus of the ear, and where the hair, the bottom of the hairline is going to be our next insertion point. And that one we're going to take straight up across into the forehead. It's going to straight up here. I don't know if you can see this from there.
Yep, and we stop right at the crest. We don't go beyond the crest.
That's right. So if you guys want to mark out the temporal crest, just so you know that's your line, not to stop there. And then we're going to take one right from the bottom of the jawline and come straight up the jaw.
And that's that line right there. And we go straight up. The thing about this one, make sure that you only go 3/4 of the way in. Whenever you use the level locks, you want at least one barb left behind because that actually helps pull on that tissue.
I think technology,
It's great when it works.
it was, but that was like maybe 3/4 of the way through that video. So we try it again or move on? Do we have the, yeah, I think we have the after.
Can you might be able to talk through the video too over top of it while it goes if it's just not the audio.
Let's see how much further let's try it.
The proper way to pop the cannula is you pop it. You don't yank because then the sponge can get caught and pull your thread out. There you go.
So again, we're going to always kind of keep our thumb on the end of the thread just in case we needed to kind of pull back to reposition. That keeps the thread from anchoring. So holding our thumb, we're going to talk about, I call it the spoon. What do you call it, Gio?
I call it the little L shape.
So it's going to be kind of face up when we go in. And we like to, some people like to pinch, some people like to put some pressure, but if we're going to kind of give a little counter pressure, I popped in, I felt the pop, and we're going to give it one more kind of twist to see if we can get the half the thread to bury here.
So you want half the thread buried because we're going to be going deep and you want to just feel that pop.
Yep.
And then
there we go.
What Rachel's going to do is drive it forward while she's pushing the tissue down over it. It keeps you deep without worrying about hitting anything we shouldn't be hitting.
Mm-hmm.
You want to be below the deep temporal artery and the superficial. Obviously, if you're below the deep temporal, you're already below the superficial. Okay.
I've hit resistance, so I've stopped. I'm going to just kind of hold a little gentle pressure here as I twist and pull out. Good.
Perfect.
Okay.
You can see that was absolutely perfect. Now she's going to go down to the one right above the zygoma.
Here.
Same exact technique.
You want me here, the lateral.
She's going to pop in, twist till she only sees half the thread. Then she's going to lay the cannula down. So you don't want to keep driving as you're twisting. Once you're in, drop the cannula. Perfect, you can drop. And then she will twist to keep getting in there because that'll keep her deep. And then she's going to pull that tissue down and over until she's about 3/4 of the way in. Beautiful. So the reason I really want you to only go in 3/4 is you need to have with these molded level locks at least one barb little V sticking out. So that catches the tissue so you can really get a good pull on the skin. If you bury it all the way, the thread at the end is smooth and you're not going to get that extra little bit of pull. So now she's at that bottom of the cheek. She's actually going deep enough to pull up a little bit of that fat pad, and that's what will give her a beautiful lift. Just there we go. And as you can see how easily once it pops in.
And I'm twisting as I go, and I'm about 3/4 of the way, so we're going to leave it.
Yep. Beautiful. And as you can see, there's not even a drop of blood.
You want to do this one or this one? This one up here. So again, we're just kind of inserting at that 90-degree angle. I'm going to give it a twist, and it's a little bit of pressure to kind of get part of that thread under the skin, and you should feel the pop. There we go. I kind of felt a little pop. Now I'm going to lay my angle down, and I'm just going to bring, this one's going to come across the forehead. We're not going back into the scalp. There, it just slid easily. I'm stopping at the crest. I'm not going past the crest. And then we're just going to twist as we deploy.
Last one.
Yeah. This was a side we struggled on to begin with.
You're not.
Yeah, I'm not really.
Give it another twist. So as you can see, the twist is the real important part of doing this one.
There it goes.
Yep, just that. You're in a good spot.
So stop.
Nope, you can keep going
Keep
just
going
a little
one
more,
more.
but I mean your
Depth-wise.
depth-wise is
Gotcha.
great. Rachel is going to engage all these threads. What she's going to do is she's going to pull up on the thread, have a nice mound there, and then she's going to push down on that tissue, and that will engage her lift. So pull up, push down, pull back. Beautiful. Pull up, push down, pull back.
And each one of those, I got a few extra clicks. You can actually physically feel it and see it raise the skin.
And she's going to pull on one of these, and you'll see how engaged and how there is no slippage.
Yeah.
There is literally, it's not slipping forward. So the Levo Locks have 2 little V's going up of the molds and 2 little V's going down. The 2 going up actually push the tissue up, while the 2 going down prevent that thread from slipping or breaking or floating.
Now we're going to cut. So I'm pulling slightly up on the thread while I'm taking and pushing down on the skin while I cut.
And the reason that's really important is you want that thread to seed under the skin and not be pushing out at the entry point. If it's pushing out at the entry point, you will find that you could extrude the thread. I've never seen a Levo Lock extrude, so highly unlikely if you've placed them correctly. But as we know, there's a chance of extrusion. Normally, a chance of extrusion is if you do not bury that end of the thread well. So it's pushing against the epidermal, hypodermal tissue, and it just wants to push out.
So our patient here was saying that she just felt a little bit of pain in a couple specific spots. So all that we want to do is just massage, and you can be somewhat aggressive with it, with the massage, and you will feel, if there's something that's kind of tethered down, you will feel the pop, and they will feel it as well, and they can let you know that they've got some relief.
That was great. I remember how happy she was
And if
after.
you saw at the after, you could really see that cheek fat being repositioned.
Absolutely. I remember how happy she was. So we've done that video. Here's some more from Jamie from Train the Trainer too.
Yep, these are all vertical enhances, and you can see how it just makes that cheek area just revolumize.
Absolutely. Move on to the next slide.
The molded mat. Whoop. There we go. Molded mats. This is another thread that is used inferior to superior. In fact, I don't like and don't teach it superior to inferior because it loves to migrate out if you use it that way. So make sure if you're using the molded level mats, you're not using it on any muscles that have a lot high activity, like orbicularis, the platysmal band. Anywhere there's a lot of muscle movement, it wants to pull on that thread. And if it's inserted from superior to inferior, it will literally pull the thread out for you. But Abby can talk about how to use it and what she loves about it.
So I will, like Gio said, I use this a lot of times as an inferior to superior thread. So I will use it in place of using a Levo Lock. So as she showed on the vertical enhance, this is what I typically will use to lock in my lift. Typically, the other thing I love about this thread is it is wonderful for mirroring. So what I mean by that, if with a patient, sometimes you don't get that cheek pop that you want. Typically what I'll come in and do is I'll do a thread in the reverse vector using my Levo molded, my molded Levo Max. And then to mirror that, I actually will throw one of our traditional threads in our traditional vector. And it just helps lock in that lift. And when I go to tighten, I get a nice little fulcrum. The other thing sometimes I'll use this thread for when locking in my lift inferior into the hairline is I actually will take, when I place my traditional thread, rather than pull it out, I'll actually kind of loop it under and bury it under. So when I go to tighten up my molded Levo Max thread, because it has that like laser cut on it, that traditional thread will actually kind of wrap itself around that and it tightens. And actually you can see it when you go to tighten it, the traditional thread will tighten and pop up the cheek as well. So just a great thread. I can speak upon my experience. I no longer use it in a traditional vector because I've had some issues where that thread does move, especially in like that perioral area. So again, this is one of those threads that I use a lot to lock in my lift. So
yep. Yeah, you definitely don't want it in that perioral. Yeah. It'll come right through.
Yeah.
But yep. The great thing about it is they slide right out.
They do great. They do great. And then it's later, it's like, okay.
So we did get a question, Gio or Abby, after watching that video. Going into the hairline, has anyone ever complained of hair loss after PDO threads?
No. And that's because we go back to it's got to be deep. I'm sure that what they're referencing is I've seen where there's an extrusion. So if it's too superficial and there's, you know, it'd be on the hair follicle and it would create tension, right? This should not be anywhere near the hair follicle. This should be deep, right? So by going deep, you eliminate any, and that's why we also stop at the round, at the curve, because if you keep going, that cannula doesn't curve around and it hits superficial and it will put some tension and give them a little pain in that area. But I've never seen any hair loss.
No, I haven't seen any hair loss either. I also, like when I first started doing these, I did have a case where I did an extrusion. This is really important when teaching providers that you always know where your tip of your cannula is. Your non-dominant hand should be doing like almost all of your work all the time. So if you don't know where the tip is of your cannula anytime, then you need to go back to basics and know where that is. With this thread, the other thing too is it's really important when taking a history. If somebody has had sculptura or radius in the temples, it's going to feel gritty. So it might feel a little different than somebody who hasn't. So it's really important during your intake with the patient. Have you had this? I've had sculptura in my temples before. I've also had these threads placed there, and it sounds like kind of nails skirting across the chalkboard a little bit to the patient. So it can be a little scary, but it's not painful. And if you have pain when placing this thread, you really need to assess your depth and where you are. And just, you know, those are the important things, but I've never seen hair loss.
Right.
Headache is the most common thing.
Yeah, headache is the most common thing. And a lot of times it's because they end their cannula superficial. And so if you're at the depth we want you, you're below everything. You're below the nerves, you're below the blood vessels. So what happens is as they get, you know, closer up into the round, if they go past the round, I can almost guarantee you pain because it's going to be irritating nerves. Nothing that doesn't go away, but you don't want that for your patient. So just know, like Abby said, it's so important to know not just where the cannula is, but where the tip of the cannula is.
Yeah. And one other thing too on this, because I did have a patient where she had a pretty intense pain for about a week. So what I did is I had her come back. She had a history of migraine. She said this pain was different. I had her come back. I took a little bit of lidocaine and injected it into the area, and I massaged very aggressively. Her pain went away within 2 hours. So sometimes as the numbing goes down, and it wasn't that she had the pain right away, it was more like we did her threads. 3 days later, she had this horrible pain. She came in, I saw her about a week later after we had placed the threads. And sometimes too, as that is lidocaine, this is really important when you are numbing, not to use too much lidocaine, because sometimes it can create that tumescence effect. Sometimes the thread can kind of catch on tissue and it be uncomfortable. And that's just one of the things like troubleshooting. Again, it was just, she came in, we did that, I massaged her. She was like, she loved her results and she was so happy. So.
Yeah, it's very, and that's, we go back to, we've seen nothing long-term, right?
Yeah.
When we do go into the scalp, that is one of the things that I have the practitioners ask if they are migraine sufferers. Because if they are migraine sufferers, this can absolutely trigger a migraine. So they need to know so that if they have to take their migraine medicine, they're ready for it.
Mm-hmm.
All right, great. And let's move on to the next slide. Gio, this is video that was you as well. So let's get it to play and audio. Fingers crossed.
So Rachel's going to start with the 19s.
I still like to pinch to go in. Some people like to make it taut and twist. I still feel like that. And I've got it halfway under the skin. I felt kind of that pop for it to start. And then I'm going to go ahead and start threading it. And again, I'm just pinching the skin and kind of pushing it over the cannula. I've still got my thumb back here on the thread just in case I would have to reposition. Here, as you're coming off that zygoma, it wants to come superficial, so make sure you staying. You may have to adjust your angle up just a little bit to keep it deep. Here I am gently applying some pressure as I start to twist the thread to deploy it. Here I'm going to go ahead and use the hemostat.
And if you really pay attention, she's not pulling on the thread. She's holding tension, but she's getting this nice little pouch here and pushing down on it, whether it's with your fingers or with retracting the thread the other way.
I find that coming in behind the thread helps get the next one in. Sometimes it's on top of, but still trying to come in at that 90 degree till you feel it pop under the skin. A lot of this is a sensory, like you really need to pay attention to how it feels when you're deploying these. It's something that sometimes can't always be taught.
And if you have really pretty well virgin tissue, it's pretty smooth usually. If they've had other products in there, whether it be Sculpture, Radiesse, other things, sometimes it feels a little catchy, but if you can feel your tip of your cannula, you know where your cannula is, you're pretty safe to move through. But if it feels like the tissue's gripping the cannula, you're probably in a muscle and shouldn't be there.
So here, she's very narrow in her anatomy. Her tissue layer is thin. So I really want to make sure here that I'm going to get enough of the thread deep enough that we're not going to be able to see it bulge.
Exactly. And you can see with how there's no indentation of the skin that she is not superficial at all. How can you tell if you're superficial? The skin will literally dip down in that area if you're too superficial.
Cool.
So as you're watching this, one of the things that we didn't point out is,
And when she's getting a little bit of tension as she's going through, if she knows she's in the right plane, what you're going through
getting
is
a
some
little
retaining
bit of
ligaments.
tension as she's going
And the
through, if
patient
she
will
knows
actually
she's in the
feel a
right
little
plane,
pop.
what you're going through is some retaining ligaments. And the patient will actually feel a little pop.
Gio, a question came in, what you're using from pain management here on this one.
to Messon, you can actually see that we use Lido with epi.
Now I'm going to go ahead and tighten these and cut them so then I can put the now I'm going to go ahead and tighten these and cut them so then I can put the gentle pressure as I'm kind of pushing the skin down so I can. So again, I'm pulling up gentle pressure as I'm kind of pushing the skin down so I can cut the threads so that they can kind of walk. There's just two here, but you still want to go ahead and twist the threads so that they can kind of walk onto each other a little bit.
Sure that it's hyper lifted so it seats beautifully under the skin, preventing the chance of migration.
So here I'm pulling a little bit of tension and traction. I'm going to give it a little bit of a twist motion. Here I'm pulling a little bit of tension and traction. I'm going to give it a little bit of a twist motion to get it under the skin. Once half of it's under, we're going to go ahead and start feeding it up, and it's a pinch together and push up, and it's a pinch together and push. There we go. Once I hit resistance, I'm done. Pinch together, push down, was in. Hit resistance, I'm done.
This is our molded max. As you can see, the molded max has a little stopper at the end, which allows you to not have to hold the thread if you want to redirect. The cannula is a little different also. It's a W, so it's a little, I don't want to call it sharper, but it's got a little more ease through the tissue, and there's no folded over thread. So when you insert this, you put it all the way in, you got to pull out a 1/4 of an inch. We're going to loosen this, pull it out as we pull out that 1/4 of an inch. Then we got to tap the thread in. You have to make sure as you're tapping, you can feel that thread engage. Then you can pull the cannula out. So,
okay, we have the cannula again. These are the molded max. We can loosen the holder for the thread instead of keeping our thumb to have to hold the thread. This little plastic piece does that for us, but you may want to just give it one little jiggle before you go to make sure it's loose enough. You can see the thread does not come out the end of the cannula. We're going to go in our track that's already numb. I just came and pulled the thread out of the way so I could get back in here. I'm in the right plane. Come across. I'm as far as I want to go. I'm going to pull the plastic piece out. I'm going to give the thread, kind of push it almost like you're threading the needle, or you can do the tap tap, and it's staying in here. So I'm going to go ahead and remove my cannula, and then we can go ahead and pull this side to tighten. I'm just going right under the jawline. I'm not really meeting anything strong and resistant. I'm stopping when we get as lateral to our line. Again, I'm going to remove this plastic piece. I call it threading the cannula or tapping the thread in. It's going to start to disappear. That tells me it's anchored. And there we go. Then we can pull to get our tightening. This is our last one. Again, we're not forcing anything. We're just letting it glide the tissue plane and back at our line. I'm on taking the plastic piece out. I'm going to thread the needle or tap, 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 and deploy.
You can see how it changed the shape of her face.
Mm-hmm.
You got that heaviness.
Great results. I remember how happy she was as well. A question came in during the video back to Abby with pain management. Have you used Botox or other talks for treating tension for pain post threads? Like, would you ever use Botox for that?
No, I mean, like I said, for her, it was, her pain wasn't from a migraine. It just was because that thread kind of was irritating a little bit of the tissue. So she did already actually get talks for her migraines anyway. So I wouldn't use that as like initial cause. I mean, way to treat it. What I would do is if a patient does have migraines, they get their talks separately from doing threads. But like Gio said, it can sometimes worsen that. I know when I had mine done, I just don't want to like lay on my husband's shoulder. I'm just like, don't touch me. Like I wanted one of the neck pillows and not to lay on the side of my head for about 3 to 5 days, but it wasn't horrible. So.
Thank you. All right, move on to the next slide.
Okay,
Now,
so this is a
yours,
patient.
Abby. Yeah.
Yeah. So this is a patient where I combined multiple techniques. I won't go through all of the techniques, but like Gio talked about earlier, I used the reverse vector. So I used the 5-point technique, which you see me here marking out on the video. For this one, I used a molded max, and then I combined it with a traditional vector using a Levo blunt, the 19 by 100s. And then I finished off, because she still had a deeper nasolabial fold, I used our 23 by 38 multi-thread and then stamped her face with Lume Envy. So what you see me here is initially when I like to place threads, I like to work from superior to inferior and then work lateral to medial, except for when I'm doing my top 2 entry sites. I'll typically place those in before I come down and do my entry site at my tragus and at my angle of the mandible. And then the important thing to remember with these is when you are combining your traditional vector with your reverse vector, you want to make sure as not to over tighten it. So usually what I'll do is if I'm kind of on the fence of like, oh, I'll probably end up putting a traditional one, is I'll put my reverse vector and tighten it just a little bit and then sit the patient up and reassess. And then essentially what I did was I mirrored this on the other side.
Great. And I love that you stamped some Lume Envy as well.
I love Lume Envy. Love Lume Envy.
Love our boosters.
Yes, absolutely.
I think we can go. Yep, and this is just kind of showing that one side done versus the other, and see how it popped her right up. So.
Yeah.
And so this is before and this is immediately after. So we see that she has an improved lid cheek junction. Also to note, I like my patients to have just a little bit of puckering when they leave. If it's too much, I'll release it before they leave. But what will happen over time is I reassure them and educate them that this will go down over time. I took the photo before I placed, so I like to use in my practice, they're like little pimple patches over that area. But some of my colleagues will actually use the little steri-strip tape, because then it hides the puckering so the patient doesn't see. But most of the time when I do this, I kind of call it a lunchtime procedure, because literally they can go out and put their hair down and you can't even tell really that they had something done. They just look more lifted. So
and that's, you can tell the difference between somebody who has confidence doing threads and not confidence when we teach, I wouldn't let a beginner
Okay.
send home a patient with a pucker. And the reason being, I'm trying to get them clinically confident. And guess what? When they get a call from their client that they have this pucker, which, as we all know, once you do these for a while, you know how easy, you just pop them down. But
Yeah.
this gives her a little bit more longevity, but it's not something that we necessarily, and if they're high anxiety patients, we may not let them leave looking like this. There's nothing wrong with it.
Yeah.
We know that it actually helps prolong the efficacy of the procedure, but we know how clients can be.
And I tell them, I essentially put them in power of their own destiny to be able to say, look, like, I hand them a mirror and sit them up before I even put any of the pimple patches on, and just say, look, like, this is going to go down, but if it's too much for you, I can release it right now. And if they say, oh my gosh, like, that's too much, then I release it before they leave. This patient's had threads done a few times for me, by me before. So, but newer patients, no, I typically won't do it unless I've had threads placed before, because they don't know how that goes. If so, I'm usually in office on Friday. So if I do it on a Friday, if I tell them, like, hey, if it's too much, call me Monday, come in, and it takes 2 seconds to just massage very aggressively over that and release it, and they'll hear a pop and they're like, oh, okay. So yeah, but I agree with you, Gio.
Yeah, it's normal, it's okay, but high anxiety patients, no.
Yeah.
Great. Next slide. And also, there's been a few comments that some of you that are live cannot see the videos. If that is the case, please email into us and we are happy to send those videos to you. Next slide.
Okay, so this is one where I used a molded mirror technique. And I will show you kind of on a model. So I used a total of 8 threads. I used a Levo molded 18 by 100. And then I also used that in a traditional technique as well. And then I used, so what you see me here doing is placing in the Levo molded. The Levo molded is a bidirectional thread, which means that it has barbs going 2 different ways. So once this video is done playing, I will kind of explain on a model so that way you have the ability to see. But essentially, I'm using the thread and making essentially like a V. So I'm going in, I'm placing the thread. I grab my model here, I marked it out. So can everybody see here? So I marked it out where my entry site is. So with this, we're going to go down about 45 millimeters to 50 millimeters of our first vector. Okay. When we get to that point at the end of the cannula, what I do is I take the skin and I pull it up over the cannula. I don't advance it anymore. Then what I do is I clip the tail that's at the end of the cannula. And when I slowly will pull back on the thread and pull a little bit out and create essentially a loop and loop behind where I came out with the thread, and then go back down and place a second vector using that same thread because it's a bidirectional thread. It's important that when you do your second vector that you go just a little bit further than your marking to make sure that the thread's buried. So on the first one, when I placed it on the model doing the traditional vector on her with that molded, so it's almost like a traditional V, I didn't bury it far enough, so you just saw me clip the tail. On the second one, going back into the hairline here, I did go a little far enough so that way when I pulled the cannula out, I didn't have any excess of the thread. So if we want to play it hopefully one more time, that way you guys can see that. And I would show you on the thread, but it's so hard to see on the webinar, on those. And I would encourage you, if you use this thread at all, to take one and just kind of look at it, play with it to be able to see that on the bidirectional, the barbs on like how they go 2 separate ways. So, and this is one where I used 4 threads per side. So I used the 18 by 100 molded, doing a V here. I did one mirroring it reversal into the hairline here. I did one here about the just in front of the tragus here to get a nice lift, and then I locked in by lift by just using a molded max going straight up to the hairline. So
beautiful.
Great.
That's such a cool technique when you flip and reverse it.
Yeah. It took me a little bit to get that finesse, but it takes a while. So if we want to go to the next slide. Yeah.
When you do.
Abby, we got a question from the last model, back to the puckering. How long does it take for it to go down typically?
Usually about 3 to 4 days. So it'll start to, usually when they leave and the numbing starts to go down, they'll notice it release just a little bit. And then when they go to pull the little acne patches off, that pulls down some of the tissue and it will release a little bit more. So I tell them if by like day 5, day 6, it's still there to call me. And most of the time I've had one patient early in my career where I just had to go and massage it a little bit. So, and this is this patient's before and after results immediately. And this is just using 4 threads. So.
Great. Awesome. Next slide.
Part of the ROI video
No kidding,
today.
right?
Yes. That's how I've been like not playing around, but using different threads to try different things. So that way, she was really, really happy. So, and funny thing about this is one of the patients I was telling you about previously who had the pain before. And so she actually said she preferred this technique over the other one. And she felt she got a better lift. So it's just fun. Like when you, she's been through with me like since day one and just has been, I don't want to say guinea pig, but has volunteered for everything. So it's just great to hear her feedback and stuff. And she loves threads. So
yeah, it's great.
And that's the thing. Some people just love their threads.
Yeah. Yeah.
Abby or Gio, to go back and just reinforce the difference between molded and molded max again. We just got a couple comments. Molded and molded max. Yes.
Is just our traditional lip. So we have the omnidirectional cut threads, and then there's the molded, which is bidirectional, like she said. And it's just, they are molded differently, right? If you look at just the regular molded, it just looks like little shark teeth. The molded max are more like a zigzag, and that's why they actually zigzag out, right? They zigzag and move the tissue and anchor it. And then the Levo Lock is just 2 little shark fins going up and 2 little shark fins going down, but they're molded. They're pressed literally in a little press and molded the threads instead of cutting them. So when you see molded thread, it's almost flat, where our regular cut threads are round because they're still in that round suture shape.
Great. Just like that first slide.
Yeah, and that's something too, where if you haven't, like when you go to cut your threads, if you're using different threads, I usually encourage you place a gauze if you haven't, just so that way you can see like and feel the difference. Or if, you at least like pull out one thread either to show patients like the difference between threads, because patients think that it's one thread fits all and it's not. So just explaining that to patients about, how the threads are different, the difference between smooth and barbed, and then just understanding that as a provider. I'm a visual learner, so for me, I had to like pull, them out of the cannula and kind of set them and feel them to be able to say, okay, before I got comfortable doing different techniques and stuff.
I think they make more sense to you when you actually look at how they are barbed. It clicks, like, oh, okay, that makes sense.
Great, thank you.
So this is a patient where we did a combination using the Levo molded, so that's that bidirectional thread, a molded max, and then using a submental dual needle. So just to kind of explain, I came in and similar to here, I did a Levo molded right here traditionally in the mid phase. I then locked in my lift using a Levo molded max going up into the hairline here. And then I came in her submental area to help tighten that up because that was one of her areas of concern where I came underneath the neck area here. So we're going to show just kind of the neck area since we showed the previous 2 techniques. The other thing with this as well, I forgot what I was going to say, but we can go ahead and play the video.
Come on, technology.
Oh, I remember what I was going to say quick on this. So for these patients, sometimes, usually I like someone with a little bit more submental fullness, but she had just kind of that little pocket underneath here that we were able to improve. But a lot of times too, before I will treat like submental areas on some patients, I typically will do neurotoxin before to release the bands. So.
Can we try to play the video? Let's see. It's paused, it's not playing. Let's see. This is a good one. All right, maybe we go on to the next slide. We can always send this video if we need to those that are listening. Oh, I think it's gonna. There you go, Abby.
So this is me placing the submental thread with dual needle. Also too, when I numb, I kind of do a lollipop technique. So it's really, really important that when you're in this area, you don't over numb. When I mark out my entry sites, you want to make sure that you're always anterior to the SCM because of the anatomy. You also want to make sure when you're using dual needle in the submental area that I will not numb over by the masseter or parotid except for my vector that I did going straight up. If I do that, they shouldn't have any pain. She had no pain. And what I love about not numbing a whole lot in this area, if not at all, is it gives me feedback to know, okay, if I'm too deep, that I'm not in the masseter, that I'm not in the parotid, and if so, then I can readjust. So she was really comfortable. She said this was more comfortable to her than Botox, which I found really unusual. So, but yeah.
And I love that technique. Look at that.
Yeah, it works great. A little tip that I recommend that I found has worked well in my practice is when I make my entry sites using a 16 gauge needle instead of an 18 gauge needle, it makes it a little bit easier to reassure that you get that needle back through the same hole without getting a lot of tissue. So that's just one of my little tips I've learned is sometimes going a little bit larger on the needle can help. So. Did
you, but you didn't make an entry point where you exited. You just exited.
Correct. Not for this one. On the other side, I struggled a little bit, so I had to come back in with my pilot needle to get in front of it. So sometimes I can get it. Other times I'm like, oh, this is a struggle. So yeah.
Right. I just noticed that there wasn't. But yeah, sometimes it pops right through. And
yeah, sometimes it pops through and other times it doesn't. So
well, and because what we did is we made sure that the needles weren't super sharp so that it does give you some feedback, letting you know that you're bouncing up against the blood vessel if you're near a blood vessel.
Correct. And then
for safety.
Sometimes too, the tip of the butt of the needle can be hard to push through. Some people have really, really tough skin. So sometimes what I recommend doing is taking like a 4x4 gauze, folding it, and then using that to protect your finger and pushing through because it can be sharp and you just don't want it to tear your glove. So these are her before and after results.
What I have to do is use the cap.
Yep. Or the needle cap of the thing, yes.
Almost like a needle driver, right?
Yep. Yeah. So, and as you can see, she's going to have a little puckering. We had talked about this before. She was okay with the puckering. With the dual needle, I find they get a little bit more puckering that can last a little bit longer. But again, when I have my patients come in, I sit down with them, I do my consultation with them. I essentially vet them to see like how they will be able to tolerate that, how they'll be able to handle the aftercare. That's the most important thing for me. I've had patients who I think would be great candidates for thread, but just do not. I just have this internal feeling, and my advice is always trust your gut. So I've done threads before where someone was crying, and it was the most like PTSD experience for me. And now I'm like, oh, this would be a great candidate, but I just know like you're just not a good fit for this, and that's okay. It's okay to say no. So
it is. I mean, if you know they're high anxiety, if you're getting phone calls from them for Botox or for filler, the last thing you want to do is put threads in. Your patients they have to first be good quality patients for threads, and then they have to also be low anxiety.
Yeah. And that's too where I'll just be like, hey, thank you for coming in. Why don't we try some Lume Envy? And then they love Lume Envy. And then they're happy. I'm like, let's stamp your face.
Yes.
Takes me 5 minutes. Let's do this.
Next slide. This is Gio and Rachel again. Shout out to Rachel for doing all these videos back a year or so ago with you.
Yes.
She's one of our trainers in Florida as well.
This is Gio with PDO Max, and we're going to talk now about some smooth threads. So smooth threads are phenomenal for creating collagen, elastin, and bringing fibroblasts to the area. We want those really more superficial, not necessarily hypodermis, but between the hypodermis and the subdermis. So we're not going so deep that you're ever going to hit SMAS with these smooth threads. They're there to stimulate the collagen and the neocollagenesis. So there's a few ways we can do it. On her, we are going to do what I call stacking. So we will put your first thread in, and then we'll put a second thread in right above that. So we'll put one in, then the second one, and that's how we're going to go with all of them. On her, we're going to be using the 30/38. How do we decide what size thread we use on people? You go by the length of the area of the anatomy. Some people have a wider area, so you could use 29/50. Most people, 30/38 is great. If they're really small, 30/25. If we were going to do barcode, and we will do a barcode on her, we will put 30/38 going this way and 30/25 going this way. So 30/38 going horizontally and 30/25 going vertically. And what I like to do is you like to pinch, and you can basically see that where I put the line is where she has a line. So you should be able to visually tell where you want them. But if you can't, just pinch and you'll see where you should put them.
All right, so on our smooth threads, these are the 30 gauge 38. And we're going to start on our bottom row first. And as Gio said, it doesn't matter necessarily which direction, as long as you feel comfortable. We're just going to go right under the skin. We're going to go ahead and lay that first one.
And while she's putting these in, let's discuss. There's normally more bruising with the tiny sharp threads than there are with the lifting threads. Why is that? Well, we're hitting that capillary layer. So and they're little sharp needles, so there is a chance you'll go through a capillary, where when we're working deeper, we're away from that capillary space and we're in more of the vein artery space, and that is why you don't shove cannulas through, and that is why we don't use needles for our lifting threads. All done.
All right, so I'm just holding the marshmallows. Some people are very technically savvy and can do all these at once. I'm a little bit more, I kind of got to do them individually.
Neither way is right or wrong. What is important is to sort of push the sponge up as you pull the cannula out or needle out, so that the thread has some counterbalance to make sure the thread doesn't come out with the cannula.
Okay, now we're going to do our
30/38. Let me get you some 30/25s.
Little pinchy here. 1, 2, 3, poke.
So I like a practitioner to come from the lip, because you're getting and breaking up where it's adhered down at the lip and help get rid of that vertical line better.
All right, deep breath. 1, 2, 3, poke.
And with these, I guarantee them a bruise, and then when they don't get one, they love me.
Great point.
So it's better to prepare them for a bruise with these than not. They're needles. There's a good chance they're going to bruise. And, when we teach, you want to keep these in that subdermis, hypodermis, and because they are needles, if they dive deep, you're going to hit something and they are going to get a bruise.
A question came in, can you use tox immediately after smooth threads?
It obviously depends where you're working. I prefer them to be toxed 2 weeks before. What do you think, Abby?
I'm sorry, what was the question?
Using
you use
tops the
tops
same day
immediately
as
after?
Oh, I tell them probably 2 weeks. Same with you. And then if they have an event, 4 weeks minimum.
Great, thank you. All right, next slide. We're nearing the end, a few more to go.
Multi-threads. These are fun.
Yes. I think we can get the video. Let's see. Yeah.
These are the multi-threads. There are 7 threads on the cannula. So lots of collagen formation, great for temporal hollows, great for marionettes, great for nasolabial folds, 2 different sizes, 2338, 2360. The shorter ones, I like to use the marionettes. The longer ones, they will use the nasolabial folds. What you want to do is you want to measure. You want half the thread to come in front of the marionette, half of it to stay behind the marionette. Why? So it literally elevates that marionette and supports it. You're not just filling it, you're supporting it, okay? So you're gonna want, well, Rachel's gonna numb right about here for us, just a little bit. And the other important thing, and you'll understand why when we go to insert it, you wanna push this little sponge down so that you have a clear vision of where the thread is folded over, because that has to bury before you start moving the cannula so that you don't have the threads pushing back on you. So go ahead, Rachel.
So we want to, we've numbed, but I need to make my poke with my 18 gauge introducer. There was a pop, and we're kind of thinking about a V pattern here with the shape of the multi-thread. And we're envisioning that is the direction. We have to get this buried. We're in with a pop before we drop our angle. Open your mouth for me. And I've got my hand inside here. I'm going to fill it so I can make sure that I don't go into the mucosa. I'm just pushing it forward. Yep. There we go.
Whoa.
Pushing the marshmallows as we pull out, and we're
What I was talking about, making sure that that thread is buried, is because if it's not, what happens is, as you're, if you're not in the dermis, if you end up in the hypodermis or the epidermis, it literally pushes the thread back towards the hub, and then when you pull the cannula out, you pull the thread all in one spot, and that's not fun.
So that was a question. Are you superficial or subdermal?
Subdermal.
Okay.
And that's why we also, you know, we have them put their fingers inside. So when we first started teaching this, almost everybody went through the mucosa. So we found that putting your fingers in there and literally sliding that cannula, you almost feel it go right between the tissue. And that's where you want it. You don't want it too deep, and you don't want it too superficial.
Great. Another question that came in was, can you use PRF before or after?
Abby?
So it depends. Okay, for me, and Gio, you can comment on this. I think it depends on the area. So I'm of the mindset if something were to happen, I want to know like what happened. So prime example, if I'm doing like filler and threads in the same day, I won't put threads in the same place I'm doing filler. So that way, if something were to happen, the only place that sometimes I will do like PRF or PRP is when I'm using our smooth blunt thread for under eyes. Sometimes I'll use that cannula that and use a little bit of PRP or PRF to come in underneath the under eyes. But this area is highly mobile as it is. So with a multi-thread like that, I probably wouldn't do PRP or PRF in that area. I just would, again, that's just my mindset as a provider. So
you called
yeah.
it the only place where we got with the PRP. We, as a company, agree 100%. You don't want, we want to know if there is an adverse event, we want to know where the adverse event is from, right? So if you've done filler and threads on the same day in the same area, how are you going to mitigate what's going on? Is it a granuloma, or is it a thread infection? Or yes, obviously we can pull out our ultrasound and figure out maybe what it is, but why put yourself through that? Space your services 2 weeks to a month apart, so you know what caused what.
Yeah.
Makes sense.
Or if I am treating like 2 separate areas, like sometimes I'll do like a reverse vector and I'll do Sculptra, but where my Sculptra is being placed is not where my threads are. So that way I know. So.
Okay, great. Gio, we did a web chat earlier and talked about tear troughs. So a question just came in. Our threads. Yeah.
You know, and the webinar we did earlier, you know, the practitioners, we were talking to Shelby and Sonia down in Texas, and they're like, really, there's nothing for the tear trough. It's just an amazing procedure, right? For skin quality. And it really, there isn't a lot that can go wrong if you know where to place them and the depth you meet them at. And you definitely, you know, we go back to client selection. You're not going to do the under eye threads to somebody who is so crepey that should get a bluff. I mean, we know the difference, or we should. So, but yeah, PRP and threads on, that's probably the one and only time I would combine.
Yeah, that was a good segue. And then lastly, what is the advantage of stacking versus the barcode?
So the difference between stacking is I want as much collagen in that area. So it's somebody who doesn't need the scaffolding, you know, when we do them vertically and horizontally, we're creating a scaffold. It's creating some strength. And somebody who doesn't need that, I like to stack just to give them a lot of collagen.
Great. Awesome. Thank you. Well, this was went longer than an hour, which was amazing. Thank you so much for all of the great questions. For those that are live and anyone that was not able to see the videos, please email us at info@pdomax.com. We're happy to send you that video. Train with the industry's best. Certainly message us for more information if you haven't trained with us before, or to learn a little bit more about our clinically confident sessions or more advanced training that we offer. And those that are on live, please, with your next order in the next 7 days, you get 10% off your next thread order. So send us an email and take advantage of it. We appreciate your time. Thank you so much, Abby, for being our guest here. And
you're always awesome.
Absolutely. Thank you so much. Bye, Gio.
See you guys later.
Bye.
Bye.